A very good afternoon to all. Welcome to this instruction course, Dodging the Bullet. We've all been operating, and whenever we are in a difficult situation, it's always better that we are sort of mentally prepared that there could be a problem, and if there is one, then what exactly is our SOP, or what exactly should we be doing? Because end result which has to be good, and that can only happen if you're prepared, your OR is prepared with all the stuff you need to dodge this bullet. So we have a faculty here. We have a keynote address by Dr. Fazli from Srinagar. He's going to be talking about pseudoexfoliation. Dr. Aditya will be talking about capsular rhexis, and Dr. Sahiba is also going to be talking about SICS. So, and I'll be talking about anterior vitrectomy as well as the small pupil, and also some cases where you've landed up with a refractive surprise and how to deal with that. Should we be doing a conservative modality, or should we do a surgical modality? So I think we'll start the session now.
You want to go first? Intraoperative.
Yeah.
Where are you, Judge?
Can you share the slides?
You put it.
So we begin with when the window closes, surgical pearls to maximize your outcome in an intraoperative meiosis. The most challenging case for us is when we've prepared very well, we've gone into the OR, and the pupil is all right to begin with, and suddenly, or it wasn't that well widely dilated, and suddenly we see that the pupil has come down. So now starts all the complications that can happen. The intraoperative challenges of small pupil are really a lot, because number one thing is that limits your visualization, and once that happens, there's a series of problems that can happen. Number one, your capsular rhexis may not be an adequate size. Once that happens, your nucleotomy will be compromised, because you will not know how long a groove you have to make and how are you going to split this nucleus. There could be an incomplete cleanup. The pupil may come down even further, and there may be an incomplete cortical cleanup, or there may be a fragment of the nucleus that has been left behind, which causes inflammation. And in case you're doing these higher-end IOLs, where you've promised a toric IOL placement, where exactly are you going to place it, and how are you going to check whether the IOL has been placed well or not? Because these are going to be the problems which you're going to face. So the first thing that we have to do when we have this is try your luck. We have the epitrate in your OT, that should be ready. And if you're lucky and you've put in the epitrate, this pupil may enlarge to a considerably larger part. And usually these intraoperative meiosis usually happens after IA. That's because you're trying to clean up the cortex behind the iris, and the pupil comes down with the fluid wave coming in. These are the cases where we've tried to do our rhexis, a small rhexis. This was a case which had a glaucoma earlier. You can see that it has a YAG PI also, shallow AC, and pupil is not dilating. So you do a rhexis which is a smaller, but it has to go beyond the pupillary margin, because once you do that, you will realize that it is easier to hydrodissect also, and also the important pearl while doing nucleotomy is stay safe. These lenses sometimes are very sticky, they do not crack, but you need to just keep on teasing them and bringing them in the center. And cortical cleanup also, if you're doing a very successful circumferential systematic cleanup, it becomes easier. This is another case where the pupil is stuck and there is a posterior synechiae. So with a Lester's hook, after putting in a good OVD, you should not compromise on an OVD in these cases. you just need to open up this pupil. This is a case where a toric IOL was required. And as I said, it's very important in a toric IOL that we need to check the axis. So once preoperatively you mark the axis, you need to again stay at the center, get the rhexis done beyond the pupillary margin. So important part here is to hold the rhexis at the margin at the end with which you have left as a flap. Hold and you pull it out. Here again, we are doing a very gentle hydrodissection. It's a sticky kind of a nuclear material. So a very gentle putting of the fluid and nudging of the nucleus is done. So that once you see, and it's very empirical in these cases that we need to see that the nucleus is mobile. Take a minute or two to do this maneuver, because here this is your end result. If your lens has moved and it is rotating easily, then things get easier. Since this was a case of toric IOLs, we are putting in these hooks. Now, whenever you're putting the hooks, the important trick here is that you need to make these paracentesis for here, as I'm doing it here. These have to be made very peripherally. Don't go too anterior, because if you do that, you'll cause tenting of the iris. And if you want to prevent, because most people say that, post-operatively you've had after the surgery, the pupil has not come back to its normal size. So very important part is that you need to know when to stretch it and when to release it. So at different parts of your duration of your procedure, you must release the iris hooks also. Don't just let them be where they are, because you can release it like I released it now. But because I don't want any of my incarceration of the iris tissue into the injector while I'm putting in the lens. And at this moment, it's quite a reasonable size dilatation of the pupil. The lens has been put inside the eye. We can see it well, and it is dialed in at the right place, right axis. Now here again, to prevent capsular phimosis, because this is a case of a toric lens, we don't want that there would be any capsular phimosis. So I do an extension of the rhexis. And taking out of the iris hooks is also very important. Always make the hook parallel to the iris. And once you've done that, and the visco has to be adequate, and then you slowly take it out. Because if you tilt it, you're going to have a DME, descemet membrane detachment there. So you don't want to do that. So this is the other few tricks during this. Now there are a lot of complications that are related to the small pupil. There could be iris damage, because especially in cases of pseudo-exfoliation or cases where there's a floppy iris, IFIS. So the iris, there's a lot of bellowing of the iris, and it gets caught in the phaco probe, or there is a prolapse through your side ports. So there is chaffing of the iris tissue. There could be just transillumination defects, which the patient complains later on of glaze and halos. So all these have to be, you have to be very, very careful and cautious. Never overfill your chambers in cases of IFIS. They should be always adequate viscoelastic. And IOL placement issues also could be there. One of the haptics could not have been put inside the bag because the pupil was small and you were not able to gauge where exactly you are supposed to leave your haptics. There could be retained lens fragments of the cortex. Now, retained lens fragments, one thing I would like to say is always hydrate the ports before leaving. And because sometimes it's just in the side port that it is one of the nucleus fragments is hiding, or in a small pupil it could be under the iris, which may later cause a CME or a glaucoma or any other problems also. And any case where you've done a lot of maneuvering with the iris, there are chances of CME. So if the patient is not having a good vision post-op, do an OCT to check and treat the patient accordingly. Thank you very much.
I think we have time for a few questions. Does anybody have a question? Okay, I have a question. When we talk about say premium IOLs, does the pupil size for you matter? And if you get a case of intraoperative meiosis, how do you ensure that? Because for me, the biggest challenge in intraoperative meiosis when I'm not using a device is if the bag, it's in the bag or it's not in the bag, if it's in the right alignment or not?
Yeah, so a word of caution here. In any time there is an intraoperative meiosis, if you haven't used the devices, then you must check that, sequentially, shift the iris, pull the iris, and just check your capsular margins. See that the lens is well within the bag. And if the IOL is mobile, it moves freely left and right, or whenever you want to rotate it, then mostly it is in the bag. So that's one of the signs in which you can test also. But you must take time to just ensure that the IOL is inside the bag by lifting the pupil and checking the margins of the capsule.
Thank you.
Yeah, thank you.
Any comment from the panel?
Very, very good videos.
Thank you.
Yeah, the Y hook is a fantastic tool to move the iris away, because most of the time the surgeon is working with Sinskey hook and retracting with that. But a Y hook is the least traumatic. It can hold the iris pupillary border nicely, and you can check all around whether the lens is in the bag. And I felt that it's a very, very useful tool.
Good tool. Yeah. Even when you're doing the IA, the irrigation probe, you can just sort of, that's only if it is not a case of if-is. If it is, then that is absolutely a no-no to do. You should not lift or go anywhere near the capsular margin. The fluid should not go under the iris.
Another thing is the relativity of what we call as a small pupil. What might be small to one surgeon might not be that small to another person. It depends upon the degree of expertise. Not only the expertise, also other confounding factors, like you said, floppy iris, very important. Sometimes you might be a little in the center, just a little away from the center, and a floppy iris can come.
Yeah.
So the decision regarding when to use the iris hooks is very critical. If you have a borderline pupil where you are not very confident about operating safely, it's perhaps better to use the hooks before you start off. It gives you a bigger rhexis and a lot of ease during the surgery. Like we saw one of those beautiful surgeries, you put the iris hooks later. But that depends on the surgeon's ease. But for beginners who are handling small pupils, I think an iris hook at the start, a pupil expander at the start of the surgery would be safer.
Also, what would be your choice of pupil expanding device in case of a shallow anterior chamber?
In shallow anterior chambers, I think hooks can work well. But only thing is that where you place your hook. So it should not be very anterior. It should be very posterior. It should be relatively on the periphery, so that it doesn't cause tenting of the already shallow anterior chamber. The rings can also be a good device to do. So between the two, you can see wherever you are more comfortable with, whatever works best in your hands. But you can use both, either of the two, I mean.
Thank you.
Thank you.
Next speaking, okay. Dr. Arun, you had a question? Okay. Please. You can use the mic, sir.
Yeah, the videos were very beautiful. You put the hook after you did the rhexis. Is there any trick where the rhexis does not get caught in the hook? Because I have burnt my fingers, rhexis getting caught in the hook and then tearing off. And then
in small pupil cases, and especially you have small pupils, I mean, there are two issues. You start with a relatively small pupil and you land up with a smaller pupil. Or the pupil was already small and it is not getting dilated with whatever you're doing, okay? And whatever you're comfortable with, because that 3 millimeter zone if you're getting and you're comfortable doing it there, adequate viscoelastic is important. Because once you do that, you're pushing behind, the capsule is also being pushed behind and you have enough space inside. But whenever you're pulling back the iris hook, always be careful not to take the rhexis margin also. And if you're using trypan blue, I think it will become easier for you. Since I didn't use trypan blue, I don't use it. So, I mean, it's a different scenario. But if you're using trypan blue, you can see the margins of the rhexis and that will become easier for you. Thank you.
Another important step you can do is that you inject a little bit of higher density viscoelastic helone where you are intending to put your hook. Just a little bolus, and it lifts the iris a little up, and then you can move ahead.
So we put it under the iris?
Under the iris.
Yeah.
Yeah.
You have to make space.
Thank you, Dr. Reena. Next up is Dr. Aditya. He is going to speak to us about capsular rexes in complex situations.
Good afternoon, everybody. I'll be talking about perfecting capsular rexes and difficult situations. I think this is a very, very important step of the cataract surgery, and one which can actually save you millions, because you don't need to invest in different machines now that are available if you can perfect your capsular rexes the way you want and how you want it. So the recommended CCC is about round and well centered. Size should be around 5 to 5.5 millimeters, and it should overlap the IOL optic approximately 0.5 millimeters symmetrically, 360 degrees, and consistent effective lens position, which is very important in your calculations nowadays, should be met. Otherwise you will have a refractive surprise. And you saw in Dr. Reena's video how beautifully she did make her capsular size the way she wanted to in her last case. So a few tips before I begin to the difficult situations is choosing the right case. When you're starting off choose the right case, use your correct anesthesia, and choose your favorite technique of doing it. My favorite is the capsular rexes forceps, and you can see how I do that. So another thing is, whenever you're injecting your viscoelastic, always do not remember, you don't need spaghetti, you need to coat it. So a lot of us just spray the viscoelastic like a spaghetti or a noodle, and that's not what we desire. And a good control, like sir suggested, you can use a high density viscoelastic also, especially in pediatric or cataracts where you expect a run out, you can use them. And pinch, grasp, take it around, and then once you have a nice flap, re-grasp, and then continue your shearing and tearing forceps till you finish the rexes in one go. That would be the preferred way of doing it. Often you may re-enter, and if you do, inject OVD, fill the bag again, and then again re-grasp near the intersection. So how do you manage difficult situations? So one first difficult situation is when it extends. How do you manage those? First thing, you need to know, why does the rexus extend? It will extend if you don't have a good visualization and you go and take a nick and you don't know where it's going and you keep pulling. It could be because of capsular elasticity or pseudoelasticity that is in that patient, a shallow anterior chamber, or a sudden moving eye and your burping of visco happens, or if there's a tendency already. So in this case, you can see I started with a cystotome. And as I'm continuing my rexes, somewhere in between you can see there's an extension which is going to happen. So I switch to my forceps, fill with OVD, and then try to pull again and again. And there's a point where I realized if I pull it's just extended too much, so I took a nick and continued my rexes thereafter. So this is one of the ways you can manage a good rexus without panicking. If you can make a judged decision and not continue, it may be a good idea. You can do this. You can also take a nick on the other side and continue from the other side. So the first nick is very important. We all know that. If you make a bigger nick or go more to the periphery, you'll have a problem. Grasp close to the tearing point. Grasp and re-grasp is very important. And whenever it's spiraling outwards, detect that first. Don't let it spiral all the way out. Another case where there was a little extension. If you can notice, the first incision took it so far off that I had to switch. Now you know why my favorite technique is the forceps. So I decided to go into via the forceps method. And then grasp near the tearing point and pull it inwards. This is the Little's technique, where you flatten it and pull it towards the center, like in a pediatric cataract you would. And then you make a nice heart-shaped rexus. Another case where you initiate with a cystotome, continue, and then somewhere down the line we realized there was an extension. Right there. So if you fill the bag again and do the little technique with the cystotome also, it's possible, and you can get your excess back and complete your excess. So those of you we are comfortable with cystotome, you can go ahead and do the little technique with this as well. Some special situations, which can often be perceived as very difficult situations, are zonular weakness, hypermaturity, use of hooks like we just discussed, aims for smaller excess. So like in this case, this is a hypermature cataract. You know it, when the moment you take a nick, something is going to go wrong. So you can just take a nick and drain a bit of the liquefied cortex so that you don't have a lot of tension there and there's no run out. Once you're done with the draining, it proceeds like a regular capsular rexus. But here also, always be cautious that you don't let it run too far. A lot of things have been advocated for hypermature and intumescent cataracts, like making a small rexus, use of forceps. I think all of them are good techniques to follow. So you decide which technique works for you the best. So as you can see, there's going to be a run out here. Expecting that, being a little more eager, I decided to make a rexus from the other side. I'll just forward this a bit. So in the end, a decent rexus which I could complete by making another nick and continuing. So in traumatic pediatric, being a pediatric ophthalmologist, I had to show a pediatric case as well. So this is a good case where there was a half and half rexus done. So after staining, you notice that there's already anterior capsular tear and there is a fibrosis with the adhesion right there, and it's difficult to release that adhesion. So the best way I could think of doing a rexus here is raising a flap, using my forceps, completing half of a rexus on one side, and once I completed that half rexus, I went to the other half and completed that half as well. So it gave me a nice rexus in the end. So when there are weak zonules, sometimes it's very easy, sometimes very difficult to get the rexus right. Like in this case, there was a sort of run out that you can see is happening. So used the Little's technique and completed my rexus without putting too much pressure on the zonules. So forceps is generally the best method in these weak zonular cases. So in summary, creating an intact rexus is critical for a safe procedure and maximize success. You must know your enemy potential, read about it, then be ready with your backup plans and go ahead and do it. Thank you.
Very nice, Dr. Aditya. Aditya, tell me, if you have an anterior capsular fibrosis right in the center, okay, so how are you going to manage that?
So generally take a nick a little beyond it and then go around the fibrosis and take it in your rexus flap rather than try to pull through it. If the fibrosis is too big, you can even try peeling the fibrosis. And if it's very big, then I think Zeptos and all also work wonders on it. Otherwise, you peel it one by one. I think Dr. Deepak Megur had showed a beautiful video where he would peel
double-handed. You need to actually use your venas. So basically what you can do is you can use the cystitome wherever you see that the area is clear and the fibrotic plaque is not there. And then with one instrument you have to lift the capsule, and the other hand you have to cut it, nick it, or cut it around wherever you can, and in the clearer area you can pull it around. So basically a mix and match of different techniques. Anything else?
Yeah, and another thing is that modern micro surgical instruments have made things very easy. That means you can go through the side port. You have a capsular rhexis forceps which can go through the side port. The chamber is formed. You're not through the main port. You're not losing viscoelastic, especially if there's an intumescent cataract. If there's a wide cataract where the intralenticular pressure is pushing the capsule outwards. So making a small rhexis and making a nick and making a bigger rhexis in a two-step capsular rhexis is also a fantastic way of, a very safe way of handling the capsular rhexis in a intumescent wide. Another important issue is that immediately as the rhexis, whatever the reason, whether we started off big or whether there are other factors, once it starts going out, a sense of stress and panic sets in. So at that time we need to just cool down, think about it again and restart, and most of the times you're able to make it.
I think you need to tame your rhexis. So even if it's running wild, whenever you leave and you come out of the chamber, always leave it like a flap. You know, the rhexis like a flap. If you leave it like that, it will never go out. But what happens is that we just see that it's going out and we just come out. But that's what one thing which you're not supposed to do. Just leave it turned like a flap and then come out. So then you will never have a runaway.
Also, how many people over here have never used a capsular rhexis forceps and are completely comfortable with the cystitome? Okay.
That's partly because I use an AC maintainer in all my cases. So
no turbulence.
Forceps doesn't go with the AC maintainer. So I have got used to using a cystitome all the time.
So then are intumescent cataracts also good in your hands with just using a cystitome?
Because the milky fluid keeps on getting washed
with the AC maintainer.
getting a clear field with the AC maintainer.
Correct.
Wonderful.
The pressure is maintained.
So I had the pleasure of witnessing Dr. Professor Blumenthal, and I assisted him in about, I think, 12 or 14 surgeries, where he picked up only intumescent and hypermature cataracts, and it was like a cakewalk. I mean, it was beautiful. He did it, and I think that makes a lot of sense.
Okay.
Thank you. Thank you.
Next.
So our next speaker is going to be Dr. Saiba, and she's going to talk about SICS, tips for all phaco surgeons.
So we'll go there.
Good afternoon, everyone. So I'll be talking about SICS, a tool which comes very handy and something that you need to be very proficient in this rat race of chasing the best phaco cases, in wanting to do the more and more complex cases. One needs to understand that SICS is basically a very often encountered fallback surgery for all phaco surgeons, but the reverse doesn't really happen. Surgeons who are comfortable with SICS don't need phaco as their backup surgery, and believe me, I've been attending talks wherein people have been placing multifocals, toric IOLs with an SICS surgery. So it's not just a checklist in the box that you do in your post-graduation just to, finish those 12-15 cases of SICS so that I can move on and learn phaco. But it's very important to be good at phaco, because it only will act as your backup surgery if you're good at it and confident with it. So I have 10 tips, assuming that everybody knows the basic steps of SICS. This will probably help in adding value to your surgeries that you're already doing. This has audio chalana hai.
Avoid complications like buttonholing and premature entry. Following are a few tips on how to make an ideal tunnel. Beginners can use calipers to measure about 6.5 to 7 mm tunnel size. An initial partial thickness scleral incision is made with a 15 size blade 1.5 mm behind the limbus. A frown incision or a straight incision with back cuts like shown over here is the least astigmatic incision. Next, gauging the depth of the wound is most crucial for a beginner. Here I am dipping my crescent heel up. Depth of the wound should be as much as the depth of the front slant cutting edge of the crescent. The crescent blade is made in such a way. Make sure that you open the mouth of the groove all along the length of the incision with the same depth. Now proceed with the dissection. The correct angulation of the crescent blade at this point will avoid wound-related complications. While dissecting the sclera, crescent should be heel up, and just before entering the cornea, crescent should be turned heel down. You know you're in the right plane when the crescent is just seen from the sclera but not clearly seen. Gently cut using side sweeping motion and tilt the crescent on the sides following the curvature of the sclera and the cornea to make good side pockets for a good nucleus engagement. Tip number 2. Side port construction. A good side port incision is a uniplanar stab wound in the clear cornea just inside the limbus. A side port at the right plane will be square configuration. This is ideal for wound stability and stromal hydration. A side port made anteriorly will be of rectangular configuration. Tip number 3. Always inject fluids or visco only after entering the anterior chamber completely with a cannula. If fluid is injected inside the wound, it can lead to Descemet's membrane detachment. Also, when injecting visco before your rhexis, when you want a deep chamber, take your cannula all the way to the other end and inject visco as you come out. This ensures that all aqueous pockets have been ejected and the chamber has been well formed. It makes the anterior chamber more stable and lessens the need for repeated visco injections during rhexis. Tip number 4. When entering the anterior chamber, keratome should be in the right plane. Carefully see that I am cutting only when making forward movements with my keratome and not while coming out, and that my keratome is always perpendicular even at the corners of the tunnel. Tip number 5. Before starting rhexis, it is very important to ensure that the patient's chin is up and the anterior chamber is well formed with visco. A large 6 mm or more of rhexis is a prerequisite for an uncomplicated SICS surgery. Make an initial opening long enough with the cystitome. First important thing is to always keep the opened capsular flap flat on the unopened side so that it looks like a mirror image. Secondly, keep the cystitome about 1 mm away from the open flap edge and give careful slow circular shearing forces to complete the rest of the rhexis. Tip number 6. If using hydroprolapse of the nucleus in the presence of a large rhexis, a continuous jet of hydro at a single point will always pop one pole of the nucleus out. It should, however, be done very gently to avoid sudden PC rupture, and also visco should be released from the anterior chamber before this maneuver. After one pole has prolapsed, use a dialer for dialing the nucleus out of the bag completely by lifting the nucleus up while rotating in clockwise or anti-clockwise direction. When doing the mechanical prolapse of the nucleus, one must ensure that the edge of the rhexis is visualized. Take the hook under the rhexis margin, engage the nucleus around the equator, lift up the pole of the nucleus out of the bag, and then rotate in clockwise or anti-clockwise direction. Tip number 7. During vectus-assisted nucleus delivery, before inserting the vectus, inject generous visco above and below the nucleus to coat the endothelium and to push the iris back. When you place the vectors below the nucleus, make sure you always visualize the edge of the vectors. If not, there is always a chance that you might catch hold of the iris and cause an inferior iridodylisis while coming out. Usually, there is no need to take the vectors beyond the center of the nucleus. Tip number 8. During cortical wash, instead of pulling the cortex fibers straightly, pulling in circular motion aids in removal of bigger chunks and reduces stress on zonules. Moreover, cortical wash from the side port is easier as the chamber remains stable. When doing cortical wash from the main port, remember, pressing your Simcoe cannula against the upper lip of the tunnel forms and deepens the chamber, whereas pressure on the lower lip opens the wound and flattens the chamber. Tip number 9. For an easy IOL implantation, you can try the 3-step simple technique. First step is to angulate the IOL and enter the AC and try to place the leading haptic directly in the bag. Next, hold the trailing haptic with forceps and guide the optic into the bag. Third, take a dialer and through the side port engage the optic haptic junction and make a careful downward and clockwise movement to leave the trailing haptic in the bag. Tip number 10. Keep an eye on the main wound when washing anterior chamber through the side port. If there is wound gape or leak through the main port or iris prolapse, the wound is not stable and needs to be sutured. Thank you.
Very good
I will
video.
be sharing top 10 tips which
Oh, started again. So very good video, Saiba. Excellent.
She has one more.
One more.
Talk about conversion.
Yeah, so having understood the importance of SICS, there are many situations which I can't even enlist over here, wherein you'll be faced with a situation where you need to convert from a phaco to SICS. It can be PCR, it can be as early as just an extension of the rexus which you can't really salvage. So how do you convert? So the SICS from conversion from a phaco is slightly different in the manner that you make your scleral tunnel, because one has to understand that this is not a closed globe. You've already made multiple side ports, main port entries, so your it's more likely to collapse. So a good anterior chamber viscoelastic, a high density viscoelastic, and irrespective of where your incision is, it could be a superior 2.2 or 2.8 incision, you can still make a superior tunnel, or even if you're doing a temporal clear corneal incision, you can still make a superior tunnel. Now the trick is when you start with an SICS, you usually take a superior rectus bridal suture, but what do you do once you've already started your phaco without any stabilizing procedures like these? So one tip can be that you can make a very small incision, little posterior to where you're intending your scleral incision to be, just to hold the sclera to stabilize the globe. So this is a case where there is a superior clear corneal incision and I'm making a superior scleral tunnel as well. So it doesn't really matter, it's not going to interfere, you don't need to panic. You can just go ahead with your clear corneal, you can go ahead with your scleral tunnel, and the corneal tunnel will blend in with the keratome entry. Steps remain the same. And always assess the wound integrity and make sure that you're hydrating even the initial phaco wound that you've made over and above the side ports. And don't forget that when you're closing the scleral wound. That's all I had to say. Thank you so much.
Dr. Saiba, what was the reason for the conversion in this case?
A rexus extension.
Rexus extension.
Yeah,
and it was
an
hard
unstained capsule.
Hard cataract, yeah. Also.
Yeah, not really very hard, but it was an unstained capsule and the rexus extended, and there was absolutely no visualization of how to salvage the rexus back.
Okay, right.
So did you try putting in the trap and blue later on?
So we did, it didn't help.
Yeah, because
yes,
we could see
yes.
some...
It also gets a little more difficult once you, even if you completely clear the visco with irrigation aspiration, there's still some challenge in staining your capsule as perfectly as when an unopened capsule gets stained.
Yeah, another beautiful tip for SICS IA, especially for the beginners, is to go with the Simcoe cannula through the side port. The side port has to be extended just a little bit so that it allows the Simcoe cannula to go in. After that, it is a bimanual coaxial irrigation aspiration, and you are able to go from the other side if the what is sub-incisional at that time was easily accessible on the other side. So later on, as the expertise increases, we know that the chamber should not collapse. You are not pressing the lower lip of the wound. That time it's okay, but initially if you go through the side port, all the fornices of the lens are opened up because this is almost a closed chamber.
Sure.
And sometimes when you know you've done a good Rexis and you're doing an SICS, I prefer to even use the IA bimanual. If my phaco machine, everything is in place, I'll just take another extra stab, and I just do IA. Like Sir said, it's a very closed, beautiful chamber. Go ahead, and it makes the process of a Simcoe much faster.
SICS has become a hybrid surgery with multifocals and toric iris being placed.
I think it's a very good tool to have, because a lot of times you don't know what's happening, and you have a situation where you need to convert. It's a necessity that you know SICS, in fact, more than even any other procedure.
Hello. I think a very big question for all of us is when we decide to convert from phaco to SICS. Because I think there is always that feeling that no, I think this is something I'll be able to manage, and we delay the conversion to a stage where then it becomes more tricky.
I think if you're comfortable with SICS and you're clear with your objectives, that is the patient, you will do it sooner than later.
Exactly. The patient is paying you for good vision, not essentially for phaco surgery. We must keep that in mind.
Yeah, perhaps the guidelines for when to convert are not something written in stone. Yeah, it will vary from person to person. It will vary from situation to situation. For example, somebody has a brunescent cataract, a hard cataract, where you're having problems with Rexis. That's the time you know that there is going to be multiple issues. You see zonular weakness with a hard cataract, you know there's going to be a problem if you delay. If your Rexis has gone too far away and you are not sure how it is going to behave during phacoemulsification, then it is better to convert. Again, it is something that has to do with a constant learning process. Everybody has to learn to step in at the change course at the right time. And like you said beautifully, that it is finally the vision that matters. And one can always counsel, even nowadays, people are marketing micro-phaco incision surgeries, laser surgeries. So finally you need to counsel and sit down with the patient and talk to the patient and tell them that there was a certain difficulty, you had to convert to a different surgery. I think that's the best way to go.
So I think in the zest to just learn phaco, sometimes we just have to unlearn phaco and learn SICS. I think we need to brush it up also, and so that we are confident, because sometimes what happens is phaco surgeons get less and less confident in doing an SICS. So that question is that is the challenge. It's you who is the challenge. So I think we need to also be an expert at SICS as much as in phaco. So I think that is when we will give the right justification to the patient.
We should not take pride in calling ourselves as 100%.
No, not at all. No. Good surgeons, that's it. Thank you. Thank you, Dr. Saiba.
Our next talk is on anterior vitrectomy, the art of anterior vitrectomy. Dr. Reena Sethi is going to take. Oh no, sir is going next. Sir. Sorry. No, sir, please go ahead. Next we have Dr. Sajjad Fazeli from Srinagar. Sir is going to give his lecture on dodging the bullet.
Welcome everybody to this afternoon session. I hope you're not feeling sleepy. So we're talking about dodging the bullet and pseudo-exfoliation. No sound? So do we have the anticipation, the readiness, the preparedness, and the reflexes and agility and the skill to dodge a bullet? No, we don't. So it's basically a phrase to narrowly avoid something or some situation that turns out to be undesirable, disastrous, dangerous, or otherwise harmful. In other words, to avoid a dangerous or a negative situation. So pseudo-exfoliation is very typical, that it presents with challenges that require careful pre-operative planning and intraoperative care. Like all other surgeries, this needs a little extra to ensure that there is a successful and safe surgery. And it does involve anticipation, a good pre-operative assessment, and before surgery we assess other confounding problems. So if a patient has glaucoma, first get the glaucoma under control, then see how well the pupil dilates. And avoid prostaglandins because of the post-operative risk of macular edema. There's a wide range of zonulopathy in cataract patients with pseudoexfoliation, ranging from seemingly normal zonular tension in the preoperative assessment to frank phacodonesis. Two preoperative signs in particular forewarn of weak zonules. Patients with very poor dilatation and obvious white accumulation of a pupillary margin tend to have more advanced zonular weakness. And one big red flag is a shallow anterior chamber despite a normal axial length. So can we be equipped like this? No, we'll have to prepare for this. Pupil expanders, capsular hooks, capsular tension rings, capsular tension segments, OVDs of different types, and IOL of different types. So we have a plan A, plan B, plan C, whatever. As the surgery moves, we have all the armamentarium, we have all the things that we could possibly require during the surgery there. So this is a small pupil. There's pseudoexfoliation. So with a pupil like this, I don't think there is any room for chances. So we go ahead and use the iris hooks. Now, the iris hooks can be used after the trap and blue is used. But if the pupil is small, perhaps the periphery, when the pupil is expanded, that time the staining is not good. So I found this very good, that you put in an air bubble and put the iris hooks and then stain the capsule. That gives it a better staining and uniform staining. Another thing is how much to stretch these iris hooks. We know conventionally we are taught not to stretch them too much, but when we are talking about pseudoexfoliation, we're constantly trying to look at the bag. So if we are trying to look at the bag during the surgery, yeah, this is stopping again. So we're looking at the capsular bag throughout the surgery, then we have to have some space from where we can constantly look. Otherwise, if we were to make a capsular axis of around 5.5, and the exposure by the iris hooks could have been enough. I'm sorry, this is working a little slowly. So once the rexis is done, then you see, because of these iris hooks, we have managed a good-sized rexis. And this would not have been possible if the rexis, if the pupil size was small. Once that is done, it is all very important, like Dr. Reena said, that we dial the nucleus, do a nucleotomy, safe way, watching the bag, do a nice cortical cleanup, and then we inject the IOL and then remove the sometimes it is good to remove the two hooks on the sides of the main port with this idea that it might, because there may be some tenting, and while you're going inside, you might actually hurt the iris there. So here we have injected first and then removed all the viscoelastic after that. The chances, here we were reasonably sure that there was no subluxation, and throughout the surgery the zonules seemed to be fine. And then there is the borderline nucleus. Here we are not sure, is it big enough, and is there any zonular weakness, because you might have many surprises during the surgery. And will this pupil finally come down as the surgery progresses? Now you can see here that we have stained the capsule, we're irrigating with BSS, which has some adaline in it also. The pupil size after viscoelastic injection has increased a little bit. And then the rexis has to be kept as much near the pupillary margin as possible. What that does is it gives us a reasonable size. Sometimes you can actually, you can move the capsular flap over the iris and move it, but not to touch the iris. Because if you touch the iris, this already plus minus pupil is going to quickly become smaller, and the pupil size will become difficult, and then there's a difficulty in surgery. You can see in the surgery that the pupil size more or less has remained the same during surgery, and we have been able to go through it without any issues. Then there's this other pupil. It's almost the same size, but you can see more pseudoexfoliation. So this is under topical. I'm putting some intracameral phenocane, lidocaine, and then staining the capsule with Trapen blue. Another important thing is that when you are going with a topical surgery, you have to be very careful that you are constantly communicating with the patient. So this pupil has not expanded much. It's almost the same. Here you see as soon as you initiate. See, this is the important part. Whenever you are operating pseudoexfoliation, as soon as you are initiating and you are seeing a dimple occurring in the capsule, then you know that the zonules are not good enough. There is not enough counter pressure. You can see here a dimple right in the center. There's not enough counter pressure from the zonules for this rhexis to proceed normally. So, but even with the cystotome, I think I would agree with Dr. Aditya that sometimes we should have both these in our armamentarium, the forceps, capsular rhexis, as well as the cystotome. Here I'm going with the cystotome, but you can see how much this bag is moving. So I decide to change course, use a forceps, and then complete my rhexis. Now, when I complete my rhexis, at this time, I already know that the zonules are weak. So you could see I put a little bit of viscoelastic under the capsule and then place these capsular hooks. Now, capsular hooks are designed for the capsule. Iris hooks also can be used, but they need more care. But they have a blunt tip, and you can go in a little more bigger in size, but they are the instruments made for this purpose. And once you have all the 4 capsular hooks in, then you know that you have literally put an external zonules and external support. But it would still be important to remember that there will be no equatorial support. These are just supporting on the sides. Now, this rotation is very critical because you know that you have to do a safe phacoemulsification, and for that you need to have a rotating nucleus. And you go in, bring down your bottle height, bring down your parameters, go slowly. This video is played at a slightly faster speed than it was actually done. And once you complete it, then there's this other step at which you can have a little problem, is this step, because if the zonular support is not good enough, you should be careful during the IA also. And you go ahead and implant the lens. No, because you could see there was some difficulty. You put in a CTR first. Now, what does the CTR at this stage do? There are a lot of controversies regarding the role of CTR when surgery has been completed and the long-term stability of the bag. But I always feel that it is good if you have weak zonules, you go in and put in a CTR and get some additional support to the bag. Once that is done, you remove the capsular hooks, do a good, very cautious IA, and remove whatever viscoelastic you have left there. Then there is another matter of a small pupil with zonular weakness. Now here I have already put the hooks going in and then doing a rhexis. Again, rhexis, I told you, as you initiate it and as the rhexis progresses, you know that there could be signs of weak zonules, which you might not have picked up preoperatively. You can see here, I'm facing a lot of problem, and you can see the bag moving on this side. So I complete this rhexis, and then I go ahead and make separate ports very close to the iris hooks, or the position can be a diamond configuration at around opposite sides, but you can make them nearby. Now we have capsular hooks and iris hooks coming together in one packing. So when you put one, you can go ahead and put through. I've removed one of the iris hooks, and for additional stability, placed it on the capsular hook. And this iris hook also I am removing and placing on the capsular margin so that there is more stability. And that has helped us go through this case safely. Here again, CTR is an important thing for stability during the surgery. Here I'm placing it before the nucleotomy. Before the nucleotomy. So it is giving us an additional equatorial support. You can see this CTR is going before the nucleotomy. The nucleotomy will not become difficult, but finally the IA becomes difficult because the capsular tags, the cortical matter, the cortical matter gets entangled in the CTR, and it becomes a little difficult, and it has to be removed tangentially. And again, this surgery has to move slowly. If we do not move slowly and we are in a rush, we might cause a catastrophe. Again, you can see the IOL has been placed and the hooks are being removed now. The floppy iris is another issue which can complicate issues further. You know how many people are taking medication, and you can see here, I have almost finished the case, but I can see now, every now and then the capsule is coming in because there is no equatorial support. So I decide, no, most of the surgery has gone well. So what I do, even though there is some sub-incisional cortex, you can see the iris coming out. This is not the classical way an iris should be reposited. So I go in again and implant the lens, hoping that the haptics of the lens will support the bag nicely. And then again, when you are going in, you should try and avoid dialing the lens. I'm just nudging it in. You could see even the haptic I've nudged in, then placing it nicely, and then removing this sub-incisional cortex. And again, here you would question that if we were in a position to place an CTR in the other cases, most probably before the surgery, you could see the capsule was coming like this. So we put some viscoelastic and put a CTR ring after we have implanted the IOL. So just to summarize, wash the lens while you're putting in an air bubble, and all the time be cautious. Watch each step. Again, you're going in, washing the Trepan Blue, watch the lens. You will see the pupil is going, do not overinflate with the viscoelastic. Do not overinflate with the viscoelastic because these zonules are weak. Look at the capsular axis, watch the bag. Watch the bag, whether it's moving or not. Move, this rhexis is moving nicely, there is absolutely no problem. You are seeing some subcapsular fibrosis also, but it's not interfering in our capsular CCC formation. Once that is done, this is a very important step, that you wash the bag while you are doing hydrodissection. You can see the bag is moving just a little bit. When I was tapping it, that time also it was moving a little bit. So I feel confident enough to go ahead and operate here. Again, the rotation has to be very gentle. You don't want any more stress on the zonules. You go in and bring down the bottle height. You're working at a low bottle height. It's important that the chop is the best method by which least stress is put on the zonules. So I seem to be going on all right. And then I don't want to rotate it, then you can see the other side, all the zonules are coming up. So I know that this side, there's a lot of zonular weakness. So I go ahead and put capsular hooks here, 1, 2, 3. Then I think that most probably if these zonules are weak, most probably the other zonules will also be weak. So I go ahead and, Anyway, so another important thing is the capsular contraction syndrome. Once the surgery is done, we know that this is a reality. So these do well with relaxing YOG laser, relaxing capsulotomies. Early recognition is very important. That's why after the surgery, the pseudo-exfoliation patient should undergo thorough and frequent examinations. You have to detect an early increase in the IOP, in the inflammation, and the IOL dislocation. So it can never be like this. Preparedness and the confidence are the key.
Thank you, sir.
Thank you.
Our last talk before we conclude, last two talks rather, but last talk is going to be on refractive surprises post-cataract surgery. Now you've put the lens in the difficult situation and you create a new difficult situation, which is a refractive surprise. How do you deal with them? Here, this side. 5 minutes.
I think we have 5 minutes, so we'll just quickly go through it.
Are there speakers from the next session here already?
So whenever there is a refractive surprise after we've done a cataract surgery, we have to just go back and see what was the problem. Is it on purpose? Hello?
Hello?
Can you hear me? Yes. Okay. So we have to just go back and see what was the problem. Why did we have this refractive surprise? Was it a small eye? Was it because it was a myopic large eye? Was it because it was a failure of your biometry? Because it was a dense white brunescent cataract and there was a low SNR. So then you have to find out whether it was the incorrect IOL formula which you used, or was it a error in the data entry, not the right lens that was given to you in the OR. So any which way, these are a couple of ideas on why we need to do a good biometry, and these are certain tips that errors can happen due to the excess indentation of the cornea. So whenever you're doing an indentation method of your biometry axial A scans, just see that you just touch the center of the cornea, don't indent it too much. And non-contact methods are always better and give you better results also. And biometry choice, always measure both the eyes in case you have a refractive surprise, or you've done your biometry and you've seen that there is a lot of discrepancies, then just go back. So we'll just go into the management. If it's a small error, you can suggest glasses to your patients, and if they're happy with it, then you're done with. If not, you can suggest contact lenses. If there's a astigmatic problem, if you feel that you could, it could be taken care of by limbal incisions or some corneal relaxing incisions, which are very unpredictable. You can do it. A LASIK correction would be another situation where you can manage it, or you can do an IOL exchange or a piggyback IOL. So this is the case number 1 where we had to exchange the IOL. The lens was in the eye, and this was operated a while ago. Patient was an outstation patient. He came back and there was a refractive surprise. Now here, the later you do, the more gentler you have to be. You have to remember there is a lot of fibrosis that has happened between the anterior capsule and the lens. So very slowly with a Lester's hook, put adequate OVD, and you need to just raise the capsule around the IOL very gently. Once that is done, put in more viscoelastic and nudge the lens. If you see that the lens is moving without causing much force onto the zonules, again put in more viscoelastic and lift the lens to prolapse it into the anterior chamber very gently. First the first haptic, and then you need to put in more viscoelastic, lift it again gently and place the lens inside the anterior chamber, once over the anterior capsule. Once you've done that, so have to always be careful. It has to be very gentle maneuvering because you don't want any force on the zonules. And the technique which I do is the scaffold technique. Once I've placed it onto the anterior capsule, I put in the intended IOL inside the bag. It's easy to dial it in. Once you've dialed it in very gradually under this lens which needs to be exchanged, now you're at least sure that your posterior capsule is well guarded. Put in more viscoelastic, and with this cutter, you can, left hand or your non-dominant hand, you support the lens and then you cut the lens with the main port, and you can cut it into smaller bits and gently take out the lens. If you feel that the second piece is a little bigger, you can recut it and it comes out very easily. And every time you doing this maneuver, see that you have good viscoelastic coating your endothelium, and then you can do this very successfully. This is another case where the IOL, it was a toric IOL, and then the lens, we had a refractive surprise. We put it through the toric calculator, and we realized that we need to rotate this lens. Again, we need to just scrape off or release all these fibrotic adhesions between the anterior capsule as well as the lens, the IOL, and a viscoelastic which we can put slowly, gradually under the capsule and release these adhesions. Once we see that the lens is, do it all around, and once you see that the lens is mobile and it is moving a bit freely, then you can redial this lens into position. But all these maneuvers have to be done gently, and the earlier you realize that there is a refractive surprise and you deal with this, the easier the surgery is. And only thing is you need to counsel your patient well. This is another patient where there was a refractive surprise, there was an astigmatism, and the haptic was not in the bag. So very gently viscoelastic was put, and both of the haptics are now in the bag, and the situation has been resolved. So basically, we need to have a good biometry tool, and our future lies with a flawless biometry. We are getting more and more close to this flawless biometry. And post-operatively, we need a lens where we can touch up according to, like age of the patient, requirement of the patient, and gradually give the patient the optimal sight which we had, promised. And the most exciting technology is by, it's developing by the femtosecond laser. It's in the priority method now, proprietary method now. So this is going to be changing, a game changer in our IOL practice as well. Thank you very much.
Thank you so much for the patient listening, everybody. And with this, we conclude the IC. And I hope we've given you a tip or two to dodge the bullet when it comes in your OR.
Yeah, we welcome the next faculty.